Assalamu alaikum. So, what is the clinical significance of the position of a paralyzed vocal fold? What could an examination of the larynx with a paralyzed vocal fold could tell us about the possible functional deficit, and how can it help in inferring the prognosis and help in selecting the treatment option? One of the earliest attempts at explaining the position of the paralyzed vocal fold was suggested by Felix Simon in 1881, who noted that the abductors of the vocal folds are paralyzed before the adductors. So in a progressive lesions, the adductors would bring about the vocal fold to the midline because the abductors have been paralyzed earlier. But in a progressive lesion, some of the adductors also be progressively paralyzed, and the vocal fold position would fall a little bit more lateral from the median to the paramedian to the cadaveric or the intermediate position. And this would also happen in an incomplete paralysis. The vocal fold will be more towards the midline, but in a complete paralysis, the vocal fold will lie lateral. There are a bulk of scientific and clinical observations that don't agree with this law, with Simon's law. It's no more accepted, but it was one of the earliest attempts at explaining the etiology of the functional deficit in the larynx and inferring prognosis, and perhaps also help in selecting the management. What we know now is that the most common position for the paralyzed vocal fold is the paramedian or the median position. The median position is just off the midline. Paramedian will be 1 to 2 millimeters off the midline. And this is particularly true for a long-established vocal fold paralysis with attempts at regeneration and some compensatory efforts. The intermediate and the cadaveric positions, further lateral positions, are more commonly seen in the acutely damaged recurrent laryngeal nerve immediately after the nerve injury. The abducted cadaveric position is not seen commonly unless the patient has suspected laryngeal trauma or he has acute denervation or suspected arytenoid injury. The consensus now about the vocal fold position of a paralyzed vocal fold is that it would take the position would reflect the sum total of the individual muscles dysfunction. And this would depend on the degree of the denervation, whether complete or partial, and the extent of the reinnervation, which is not uncommon in vocal fold palsy, and any contractures or atrophy of the vocal fold muscles, and also the anatomical variations between individuals in terms of the vocal fold muscles mass and the length of the vocal fold and its stiffness. And in addition, any compensatory laryngeal movements that may take place with time, plus other that we are going to discuss later in this presentation. Among these other factors that can change the position of the paralyzed vocal folds are external laryngeal forces from outside the larynx, including things like strap muscles of the tongue, for example, of the trachea or the pharynx. And these forces can change the position of the larynx and the neck. The larynx could be elevated. It could also rotate in the axial plane under the influence of intact cricothyroid muscles, for example, or tilt in the coronal plane with the effect of the strap muscles. And these changes could also bring about medialization of the vocal fold, stretching of the vocal fold length, and also elevation of its level. All these are external laryngeal forces. And nowadays, 150 years or so after Simon's law, we can answer the question of the clinical significance of a paralyzed vocal fold position better because we have better instruments and tools. We have flexible and rigid scopes that can visualize the larynx better. And we know that the flexible scopes may alter the position of the vocal fold a little bit depending on where we centralize the tip of the scope. But nevertheless, it's the preferred method, initial method, because it allows for a longer testing, so that if you are using, for example, specific laryngeal tasks, you could still keep the flexible nasolaryngoscopy for a longer time. On the other hand, a rigid scope would pull out the tongue. It's necessary to pull out the tongue to get the tip of the rigid scope in view with the larynx, and this may alter the position of the paralyzed vocal fold. We also now have better instruments like laryngeal stroboscopy and could ask for specific laryngeal tasks to clarify the exact range of the dysfunctional vocal fold and the functional deficit. So we're not only just interested in the vocal fold position, we are also interested in the two vocal folds position, the contralateral vocal fold position, because that can also affect the choice of the selection of the treatment. And we are interested in the level of the vocal fold, the mass of the vocal fold, and its range of mobility. We are also interested in the glottic configuration, the gaps left, whether it is mid-glottal or posterior, and whether the arytenoids, the two of them, are involved in malrotation or displacement, and whether there has been any ventricular folds hypertrophy, and if there is any glottal rotation, which is usually associated with high vagal nerve injury or external branch of the superior laryngeal nerve injury. So we may start with this first question. Is it really a vocal fold paralysis or just an immobile vocal fold? Because there are other reasons for an immobile vocal fold, including vocal fold paresis, which is an incomplete paralysis of the fold due to a partial injury to the nerve, or is it arytenoid fixation or arytenoid dislocation or superior laryngeal nerve palsy or scar tissue in the subglottis or the glottic area that may cause impediment of the mobility of the vocal fold. And in cases where the diagnosis is not very clear, you may use specific laryngeal tasks that would bring about further clarification about the diagnosis. These include repetitive phonatory tasks, rapid repetition of a long E for adduction and hey for abduction, or you can use rapid alternation between sustained long E and a sniff, and this maneuver should bring any asymmetry into evidence between the maximum adduction and maximum abduction. Or you could ask the patient to raise up his voice pitch, and this can be easily carried out by a glissando maneuver, and during the highest pitch you could activate the cricothyroides muscle if this is intact, and you could see the effect of raising up the pitch on laryngeal rotation, for example, towards the paralyzed superior laryngeal nerve side. Small amounts, it's unusual that the paralyzed vocal fold is absolutely stationary. There may be a bit of rocking movement or slight movement in it, either by the interarytenoid muscle, which receives bilateral innervation, so it can have some innervation from the contralateral intact side, or from the action of an intact cricothyroid muscle, or just the passive displacement of the paralyzed arytenoid by the adduction of the innervated arytenoid. All these three factors could bring about some movement of what is actually a paralyzed vocal fold. Now, the next thing after registering the maximum range of abduction and adduction of the vocal fold is to concentrate on the vocal fold level, knowing that during abduction the healthy vocal fold will rise higher up than the paralyzed vocal fold. So during deep inspiration, the paralyzed vocal fold will remain in position, while the active vocal fold will be higher when it abducts. Now, during phonation, the situation may be quite variable, because if the patient is using the greatest compensatory efforts to phonate, he may bring about the innervated vocal fold lower than the paralyzed vocal fold position. But in other cases, the paralyzed vocal fold would still be lower than the innervated vocal fold during abduction and also adduction. This level mismatch between the paralyzed vocal fold and the normal vocal fold is important to recognize, because even if the two vocal folds may meet closely in the midline during phonation, if there is a level mismatch, there will be a persistent glottal opening during phonation, and this will give a breathy and a weak voice. The next thing is to watch for the effect of high-pitch phonation on the glottic configuration. In abduction, in the abducted position, the paralyzed side may have a shorter vocal fold, what appears to be a shorter vocal fold with some bowing and arytenoid tilting forward. If this is partially or completely corrected during high pitch phonation, like in here, you see how the vocal fold is stretched, how the arytenoid is now, the position of the arytenoid is now partially corrected, and how the paralyzed vocal fold is medialized a little bit, then this suggests that the superior laryngeal nerve on this paralyzed side is intact. This phenomena of increasing tension and length of the paralyzed vocal fold and in vocal fold paresis, incomplete damage of the vocal fold innervation, can actually be used by some patients to bring about more medialization of the paralyzed, partially paralyzed vocal fold, stretching it more, and they can produce this by raising up the vocal pitch, what is termed as paralytic falsetto. Now, next is to focus attention on other compensatory mechanisms of the larynx in case of vocal fold palsy, including ventricular band hypertrophy. In this case, there is a left vocal fold palsy, and you could see that the right ventricular fold has hypertrophied and is pushed medially during phonation. It's actually closer to the other vocal fold than the right vocal fold, and this would bring about some glottic closure during phonation, but the quality of the voice here would be strained rather than just breathy and dysphonic, rather than just hoarse and breathy. There will also be an element of strain due to the ventricular oscillation. And then we look at the mass of the paralyzed vocal fold, and as you can see here, this paralyzed vocal fold is atrophic with loss of mass and evident bowing, and this will bring about a level mismatch, a height mismatch, and a dominant open phase during phonation. The next thing to notice is the arytenoid position, the ipsilateral and the contralateral arytenoids. The ipsilateral arytenoid on the paralyzed side may be displaced and tilted forward in case of severe denervation, and this would not only shorten the vocal fold, and also it would provide a level mismatch between the two vocal folds. The ipsilateral vocal fold will lie at a lower position. Jostle had noticed that this floppy arytenoid can also be displaced laterally on contact with the normal arytenoid during phonation. The normal arytenoid would just push this floppy paralyzed arytenoid laterally. And this is what is called as Jostle sign. Jostle sign would explain the posterior glottic gap during phonation because the ipsilateral arytenoid will be displaced laterally by the active arytenoid, leaving about this posterior gap. The other clinical importance of this sign is that when there is an immobile vocal fold and an absent Jostle sign, this may indicate that the cricoarytenoid joint on this side may be dislocated or may be fixed. So it is a suggestion if the Jostle sign is absent to look further into possibility of cricoarytenoid dislocation or fixation, particularly after a history of recent trauma to the neck or intubation, and if there are any signs of arytenoid edema or erythema. The next item in the laryngeal examination would focus on the gap between the vocal folds, the glottal configuration during adduction. There may be a persistent glottic gap either in the middle of the membranous part of the vocal fold or all through middle, anterior and posterior, or to this you may add arytenoid rotation or displacement. The mildest glottal gaps would be a mid-glottal gap. Looks like a spindle glottic gap. Notice that posteriorly the arytenoids are meeting well and there is no posterior gap. There may be a bit of flaccidity due to loss of tension in the paralysed vocal fold or some bowing, or there may be a level difference between the two vocal folds, a level mismatch, and this will give this appearance of the spindle-shaped mid-glottal gap. The voice will be breathy, but overall it will be better than the other two types of glottic gaps in terms of things like phonation time. It would have a better phonation time and lower mean phonatory flow rates. Or the glottal gap may be combined anterior and posterior, a gap between the membranous and the cartilaginous part of the vocal fold. The gap would then be, rather than a spindle-shaped gap, a triangular or a V-shaped gap, because the two arytenoids would not meet in the midline during adduction, plus the gap between the membranous parts of the vocal folds. These patients would have a worse voice than the mid-glottal gap patients. They would have a very breathy voice of short duration, and they also have a very limited dynamic range. In addition, they may also describe aspiration, particularly to fluids. The importance of recognizing this type of a gap is that these patients would not benefit from a medialization procedure for the paralysed vocal fold by injection or by implantation of entheroplasty type 1 because of the persistent posterior glottic gap between the arytenoids. These patients would also require an arytenoid stabilizing process in addition to the medialization procedure for surgical rehabilitation. The third type of gaps is a posterior glottic gap combined with arytenoid malrotation. So there will be a gap involving anteriorly between the two membranous parts of the vocal fold, posteriorly between the two arytenoids, and in addition there will be a misdisplacement of the arytenoid cartilage with the corniculate and the cuneiform cartilages falling forward over the paralysed vocal fold. The paralysed vocal fold will look shorter and a bit bowed with loss of tension and would be at a lower level than the active vocal fold during respiration or abduction. And during adduction, during phonation, the active vocal fold may be at a lower position sometimes even lower than the paralysed vocal fold, but there will always be a level mismatch between the two sides, giving rise to severe dysphonia and also aspiration. Here it is the right side which has the vocal fold paralysis and the arytenoid displacement, and as you can see, the forward tilting of the arytenoid during abduction and adduction prevents good closure of the glottis, because the active arytenoid would just displace the paralyzed arytenoid laterally. In addition, there will be this persistent gap during adduction, with giving rise to difficulty with voice and swallowing. This is the type of patients who would require a procedure to stabilize this arytenoid, in addition to any medialization or any augmentation of the paralyzed vocal fold. Now, some patients would present with a suspected vocal fold palsy because of breathy voice, and examination would show no visible glottal gap, but the patient would describe either a breathy phonation or voice fatigue quickly. This could be the case in some patients with vocal fold paresis, partial paralysis of the vocal fold that is incomplete and maybe only partial, and in some patients who have superior laryngeal nerve paralysis, and also, of course, in functional dysphonia. In these cases, we'll be looking for a posterior glottic gap during phonation, posterior even to the vocal process of the arytenoids. But the definitive diagnosis would rest on the use of stroboscopy, which would show some features like phase asymmetry, or this phase asymmetry is the timing of the lateral and medial displacements of the vocal folds between the two sides is different. And this can be attributed to either asymmetry in the vocal fold masses between the two sides or the tension. Also, the mucosal waves will appear earlier and travel faster on the normal side rather than the contralateral side. In these patients who present with symptoms of breathy voice, short phonation time, and voice fatigue, who by flexible laryngoscopy have no apparent vocal folds gap during adduction, stroboscopy can be valuable. The features of abnormalities during stroboscopic examination would include incomplete closure with abnormal glottic configuration, or predominance of the open phase of the glottic cycle, or abnormal amplitude and mucosal wave propagation between the two sides, or a phase shift between the two sides, asymmetry of the vocal fold vibration, or intermittent aperiodicity. These more subtle changes can only be registered by stroboscopic examination. And some of these stroboscopic features will be illustrated here in this case of incomplete left vocal fold paralysis, just a paresis of the left vocal fold. And you can see signs of a phase shift abnormalities. In frame number 4 here, you could see that the mobile right vocal fold is almost in the midline in adduction, but the left vocal fold is starting to open up, to lateralize. In frame 7, the paretic vocal fold is in maximum opening. The right mobile vocal fold is still in adduction. So there's a phase difference between the two sides, with a persistent glottic gap due to this phase difference, leading to a dominant open phase of the glottal cycle and also a reduced peak glottic area. These diagrams would explain the phase difference effects. The upper traces would show the opening and the closure of the glottal cycle, the vocal fold oscillation during a glottal cycle. you could see that the two vocal folds, the right and the left, are in phase. They open together, they start closing together, they close together, and then they start opening together. And this is just a sort of a mirror like between the two sides, and this is clearly shown in the glottal edge tracing here. When one vocal fold opens up, the other is doing the same. When they close, they are closing together, and the cycles are repeated. But when the two vocal folds are out of phase, like in these traces, you could see that one vocal fold is adducted, but the other is abducted. And by the time the abducted vocal folds start to medialize, the contralateral vocal fold has now lateralized. So there is always a phase difference between the two sides in most of the frame. The glottal edge tracing would show that when one vocal fold is opening, the other is closing. When the upper one is closing, the lower one would demonstrate opening. So there is no clear open and close phases here. And instead, you have this pattern, which is called a snake dance pattern. Snake dance effect when there is a phase difference between the two vocal folds due to change, for example, paresis or paralysis of one of the vocal fold, changes in either tension or the mass of one vocal fold in relation to the other. And one last item is the rotation of the larynx during laryngeal examination, during adduction, during phonation. This was first noted earlier in the 20th century by Weygand, that in cases of superior laryngeal nerve paralysis, the glottal chink would be oblique rather than exactly vertical. There would be a rotation of the larynx with the posterior commissure rotating towards the site of the paralysis. This would lead to a shorter and bowed vocal fold on the ipsilateral side. You could also see that the aryepiglottic fold is much shorter on the ipsilateral than the contralateral side, and that the piriform sinus on the contralateral side is opened due to the rotation of the larynx. Further reports and research into this phenomena of laryngeal rotation had confirmed that the larynx actually rotates when there is a discrepancy between the two cricothyroid muscles' function. But this could lead to a rotation of the posterior commissure either to the ipsilateral or to the contralateral sides, as we shall explain in the next slide. But the phenomenon of laryngeal rotation is confirmed, and you may have to show this by asking the patient to alternate rapidly between maximum adduction and maximum abduction, or with maximum abduction during sniffing and with maximum adduction producing a very high-pitched E to activate the cricothyroid. In that case, you could see about the deviation of the petiole of the epiglottis to one side and the posterior commissure to the other. Now, in about 50 to 60% of the cases, this may happen. The deviation of the posterior commissure would happen either to the ipsilateral, paralyzed side, or the contralateral, and vice versa for the deviation of the petiole of the epiglottis. Here there is a right-sided external branch of the superior laryngeal nerve paresis, and during abduction the glottal chink remains central in the midline, and the same would be seen in phonation during adduction at a normal pitch and loudness. The glottal chink will still be in the midline, but while producing the highest pitch during an upward glissando, for example, you could see this rotation of the petiole of the epiglottis towards the paralyzed side and a mild rotation of the posterior commissure to the contralateral side. This can be explained by either the rotation of the cricoid in relation to a fixed thyroid cartilage, or vice versa, the rotation of the thyroid on a fixed cricoid So the larynx could rotate either towards the paralyzed side or towards the contralateral side due to either the rotation of the cricoid or the rotation of the thyroid in relation to each other. By this, we come to the end of this presentation on the clinical significance of a vocal fold position in cases of vocal fold palsy. Assalamu alaikum.